Thank you.
Yeah.
Thank you. Hi guys, my name is Tyson. Nice to meet everybody. This is John. Hey, I know it's difficult being the last thing standing between you guys and a cocktail, so we'll quickly and make it interactive. But if you guys want to get cocktails, help yourselves. So I don't know. Does anyone know who Medigate is? Has anyone heard of our company? Okay. Any customers or anyone ever has anyone ever seen our platform like in a POV or? Okay. Cool. Hey, before we get started and kind of talk about, I'm going to give you a little high level of Medigate for just a minute or two before we jump into our module, which is focused on the clinical side of the house and really operational efficiency and device utilization. John and I have been hanging out since we were 3 years old. So I don't know how many, so I'm in my late 40s. John's older. I don't know how many of you have had friends for 40 years that you still want to talk to, but that's the case. So if he and I start acting like we were in high school, that's the reason why. By the way, John was also a NFL Super Bowl champion. So afterwards, we can buy a drink and tell you some stories. Okay, so before we get started with clinical device efficiency, at a very high level, Medigate's been around for just under 5 years now. We're a startup. Our technology is based out of Tel Aviv, and we really came to market as a cybersecurity company. And when the organization was seeded, there was really 3 business drivers as to why we started the company. A was to really the gap in understanding and fingerprinting passively connected medical devices. We call it IOMT. And we can even expand that a little bit around, and so when you think about what is a medical device, generally people say whatever a class 1, 2, or 3 FDA approved device is, but there's a lot of gray area around what we call really clinical IoT. This is going to be like the connected beds, thermometers, zebra printers, stuff that you're going to find connected to the clinical network. That is not actually FDA approved device. And so, back in 2017, when Jonathan and the 2 founders had the idea, the real main driver here was the gap to passively identify connected medical devices. The second big driver was we also understood that from a biomed or clinical engineering perspective, most of those teams, and I'm sure most of you guys are in that side of the house or understand the side of the house, from a legacy perspective, they were really tasked with the maintenance of these devices, but they didn't really understand the cyber side or the cybersecurity side. It's more of these devices are now online and require connectivity to the network to provide better, more efficient healthcare, more effective healthcare to patients. There's a really huge gap between clinical engineering business units, IT, and security units within the clinical setting. And third, which we thought would be down the road, and we've been really pleased, more than our wildest dreams. We had hoped, because of the way that we identify these devices passively, and I'll touch on that in a second, we had hoped that we would be able to come up with some utilization metrics to potentially provide some data or some business analytics that would effectively assist biomed or clinical engineering teams with understanding where their devices are being utilized. Okay, and that's Medigate. We closed our A round in December of 18, our B round in late 2019. We've been named best in class by Fast as the best healthcare IoT platform. Again, we're a cybersecurity company, but we've really focused a lot of our efforts on what we now are calling clinical device efficiency. And that's really around the utilization of these devices. Where are they? When are they being used? As well as operational efficiency, meaning how can I leverage devices that are underutilized to assist with capital expenditures of new devices, stuff like that. Does that make sense? Okay, now do those kind of 3 reasons that I mentioned were the drivers as to why we started the company 4 or 5 years ago. Are those challenges you guys are faced with on a daily basis? Or if you guys want to open it up, what are some of the challenges you guys are faced with regards to connected medical devices? Anybody? Does anybody know where they're, like, does anybody understand like where the inventory of their devices are? Challenges around those? Yes, no. What about you, Matt? Say that again? So do you see there's a gap on the clinical side with regards to identifying devices? Okay, cool. And are most of you guys leveraging some kind of like back-end CMS platform? Okay. How does all that data get into your CMS platform? Is it being done manually? Anybody? Tough crowd.
I'll help out here. So it's usually manual, and it's over time. And when it's manual, you have humans, and humans make mistakes. And
like,
so
garbage in, garbage out, right? So regardless if you're with Nuvolo or ServiceNow or Minuteman or Accruent, whoever that is, all great companies, we integrate with all of them actually. We can feed real-time data into those platforms, okay? And so whatever that GUI or that holy grail, if you want to call it from a clinical engineering perspective, is that your teams are actually looking at on a screen, you know, how is that data getting in there? How do you know what devices are still actively being used? What devices, how are those devices being utilized? Whether it's an MRI machine, whether it's your fleet devices. What are those devices connecting to? Where are they from a geo perspective within the HDO enterprise? Does that make sense?
And I did reverse expo earlier, and I had 3 or 4 leaders all tell me we don't go, we're 30 to 40% off on our notorious CLAs. We just, I said, I call that the dirty little secret that everybody feels guilt about, but everybody has the same problem. And what we do solves that.
And when you think about this, so Medigate was really our IP, if you will. We are a network-based tool, and we look at the packets of information as your connected medical devices or IoT or clinical IoT are communicating back to EMR user. Okay, we're passively looking at that packets all the way up to the application layer, thus being able to derive all of this very important data. Now, it's not just about the IP and the MAC address or what type of device it is, but it's all the way down to the it's all the way down to, there's like 18 or 20 what we feel like unique identifiers. Type of device, what it's connecting to, the OS, if it's out of date, if there's a patch, where's some of the other big ones, John? Location. Yep. Serial number. Okay, so I know serial number is huge for you guys, and we do this all passively because we're going all the way up to the application layer. Thus, using data, we're able to derive a lot of metrics around utilization as well as operational efficiencies for your devices.
2 things about that. The first reason why this is even possible now is because of the Records Act. As part of Obamacare, all these connected medical devices all of a sudden now have to send this data every time they do something. And so that allows us to passively watch the core layer where the network converges and gather that data. And then what's very unique about us is we are not generalists. All we do is healthcare. And the reason is because the protocols, or what I call the languages of all those connected medical devices, they're very unique and they're kind of Wunslers. No, it's just that company, it's private information, and we either work with the manufacturer or we jailbreak it ourselves and we build out this glossary. And that is how we get to the ability to create that much data and really get down to serial number, utilization data, location data, because we actually understand the languages. And that's to me what really makes us different, is that this is all we do and we're very good at it. We get this deeper level of data and good data.
So there's a challenge, which is really spun out of our ability to see utilization and operational device efficiency metrics. But does this sound familiar? Is this a problem in any of your customers or any of your hospitals? Or okay,
So I call the fusion pumps the bane of clinical engineering's existence. Okay, the people that, if somebody solved this, let us know, because we'll add a business to what we already do.
So, using the Medigate platform and what we call the CDE engine, and it all begins with turning the lights on, for giving you real-time visibility. And John, I call him Hesse, so Jay Hesse. Goes back to first grade. So what Jay Hesse was saying, with regards to really us being able to passively identify this stuff, it really starts with turning the lights on. Okay, and then we use this data to understand location of devices, potential utilization of devices. We go into the depths of that in a second, as well as your inventory. And I think where it all begins is visibility and inventory. That's how you're going to put a strategy together, whether it's a cyber strategy, an IT strategy, a clinical strategy, whether it's how do you know from a capital expenditure perspective what kind of devices you guys should be procuring this year.
Yeah, knowing what you have is the first step, that visibility piece.
Sorry, guys. Okay, and so how do we do this? So again, it's passively, and we start looking at network traffic. We integrate all the way up to your ticketing systems, your CMS platforms, your NAC, your firewalls,
Active Directory,
PACS. We have a deep integration and exclusive integration with Cerner.
So the easy way to think about it is our base layer of data comes from that passively watching the network traffic, and then we augment that data from all these other sources, including we're getting into manufacturers. And that to us is we're really becoming a collaboration tool, that single pane of glass where you can gather all this information and go to one place to see it.
Questions so far? There's all content. And so this is what we call like the Medigate's clinical device efficiency. And so what does that give you? It gives you specific benchmarks around your utilization, what devices are being underutilized, what fleet devices are being used 10, 20% of the time, what devices have been on the network 6 months ago, but now maybe retired. And obviously the idea here is to give you very hard ROI and visibility into your financial costs around
and I think this is important here also, because we're in 100 hospital networks in 1,000 hospitals. We've got a data set of, and we look at it based on children's hospitals, regional hospitals, larger hospitals, so that you can see, hey, how am I doing the benchmark versus people who play in the same space that I play in. And so we think that's the kind of information that people want, and we have enough data now that we can allow you to look at what everyone else in your group looks like and see how your numbers match up to them.
Yeah, from a market perspective, here in the U.S., Medigate currently has 105 paying customers, and that is that's 105 healthcare systems. We're deploying over 1,100 of the 6,500 acute hospitals in America, so we have about 15% market share in our 4 years of working. So here's kind of what I was talking about in the beginning: is our healthcare is our core competency. I don't know if you guys have heard of Zingbox, which was purchased by Palo Alto a few years ago. Heard of Armis? I actually ran Armis from C to B round, and then some investors said you have to go meet this Jonathan Langer guy, and this is back in 2017. And I knew from Armis is a great IoT company. As we were ramping up Armis, I tried to go into a number of different healthcare systems with them. Some 2 or 3 of the largest healthcare systems in America at the time. And while they're a great IoT platform, I realized very quickly that an IoT platform is much different. In the healthcare setting, the HDO setting, there needs to be a really different strategy than something that works in a corporate setting. And so when our investors said, hey, you have to go meet this Jonathan Langer guy, and they presented basically what you guys are looking at, a little bit differently, obviously, because no one had given us $1 for our platform at this point. But they said really to me, look, this is our vision, and I knew if they could if they could deliver 25% of really what their pitch to me was, then it'd be really, really effective. And it really started with healthcare is the only thing we're going to focus on. And so, within 3 months of being in the market, we did a deal with Trinity based out of Detroit, and they since have renewed a multi-million-dollar deal with us. We brought Andy Anderson on right away. And really because of our go-to-market strategy being focused on healthcare only. And, kind of what John said about the different protocols. I mean, how some of your Da Vinci robots or your MRIs are communicating within the network and within the EHR EMRs are a lot different than how security cameras are going to communicate. The protocols, we call them exotic devices. They're very, very hard to identify using more of a legacy or corporate style IoT platform.
And let me just go into that. What most of our competitors do, and this works in general industry, because in general industry, if you knock something down, you get a bunch of help desk calls. You can't do that with medical IoT. It's connected to a human. And so effectively, the best way I've heard it put is, I see this guy over there, he looks Chinese and speaking Chinese. That's AI, okay? He's Chinese. Because we understand the languages, we can actually get context into that conversation and understand, yeah, he's from Shenzhen, and they're going to lunch next week, and this guy over here doesn't want to go to lunch, and then he's married to his sister. That's the kind of deeper level of context and data that, because we understand the languages, that's what makes us different, is that base visibility. And it is very different than AI.
Sorry. Okay, so as we kind of think about the fact that Medigate can identify very granular real-time inventory, utilization, analytics, where your devices are, but so what? So how does that, what does that mean for you guys when you're actually trying to apply this to your environment? When the CFO is asking, how am I going to save money, make money, mitigate my risk here based on a platform? This is how we do it. And we do it by not just leveraging technology, but industry experience around the medical device workflows, the utilization, and really laying, I don't like the word services, but laying a program over this data that's specific to your data set, specific to your environment, specific to your business challenges. It all begins with discovery. Okay? And, since we started the company, the Medigate journey has really pivoted and really based off of our customer feedback, or the market feedback. The one underlying gap that we can close for every single HDO out there is discovery and true inventory analytics. And that's where it all begins. When you think about that, John mentioned that on average, when we come into an organization, even if they have Vivolo and those CMS platforms are not tasked with inventory. It's generally what we call foot soldiers who are going out in the marketplace, and you guys are either infrared scanning and putting a sticker on through the back door, i.e. procurement of new devices, or you're having some teams go out once a year and do some kind of inventory. Maybe they're writing them down, maybe they're scanning them, and then they're manually entering them into a CMS platform. On average, we see a 30% discrepancy, not only in devices that are actually touch the network in 6 months, but devices that haven't, and devices that are actively being used. So that's a 30% delta, just understanding what you're dealing with. And so, regardless of if we're talking to a security team, an IT team, a CFO around capital expenditure, you guys, i.e. the biomed, clinical side of the house, how can anybody come up with any type of strategy if you don't know what you're dealing with? Okay, and so that's where it all begins. I know a lot of consultants out there in the marketplace, the big five, which we do work with, the Boozes and the Accentures and the Deloittes, et cetera, I know that they have a lot of assessment type of offerings. And, I don't know, I think I've seen their contracts. I think it depends on how much money each organization spends with these type of field, but I've seen up to like $250,000 for them just to come give you an assessment. And they're going to go out and send those same foot soldiers out, well, like different people, but humans out to try to give you some idea of what your environment looks like. Okay, so until like true discovery and visibility into what you're dealing with is addressed, how can you come up with any type of strategy, whether it's around ITIS? So Medigate can do that within just 7 to 10 days, and because of our 165 medical device protocols that we have deciphered, or what we really have intellectual property for, just from our software running, and we do not leverage AI. How are you going to come up with really, your strategy? The first area, once you get that visibility, is to really assess your vulnerability and risk identification. What device we're communicating with PHI data not encrypted? Okay, I would say you probably want to clean those up pretty quick. And then you kind of start getting into formalizing and deploying your program, your mitigate and remediate process. So, if there are 50 devices with an OS that's outdated, or there's a patch from Philips, what is the biomedical engineering team doing about that? And how are they working together with information security or with your incident response team? Okay. We can tend to, once we put a strategy around really what we call mitigate and remediate, we get into monitoring, contextual alerting. This is more on the security side, but very important to biomed as well. Again, it goes back to what devices are communicating to North Korea, what devices are communicating to Russians, what devices have not been on my network for 6 months, and why are they still on my CMS platform? And then finally, when we get to really visibility, turning the lights on, and coming up with a strategy that encompasses all the business units within the organization, we start talking about operational efficiency, really understanding, how devices are being utilized each day, what devices, where my devices are within the organization. How can I take these data analytics? As the CFO has just issued a purchase order for 500 more infusion pumps. When I have 2,000 infusion pumps, and only 1,300 of them are being used during the week. Okay, where are those devices?
Hey, that's a really key point. Not everybody thinks about this, but there's really never ever been a data set for a CFO to make a financial decision around infusion pumps. Here, basically, you guys say we need 500 more infusion pumps. He says, why? Because we do. And because there's no data set, or hasn't been a data set, if the hospital needs them, he doesn't get them, it's on him. So he's probably going to get them. Well, now, whether it's the right decision or the wrong decision, we have a data set behind it that shows your infusion pumps and what the percentage of utilization is across the board.
Any questions? Is this interesting? Are you guys ready to get the hell out of here? Tough crowd. So, yes.
Is it real-time data? I mean, is it like, constantly coming in, and then every time you can know exactly where a device is?
We're not taking just snapshots.
Yeah.
It's real time. We're always just looking at those packets as they communicate.
So I think we should say near real time, but when the packet comes through, okay, when that medical record goes from the infusion pump and is sent to the electronic record management system, as it passes through our collector, we gather that data, and where it's at, the node it's at on the Wi-Fi pops up. So it's a continual building of a data set, and that's where we get the utilization piece, because every time it does something, it tells us what it's doing, and we understand deeply what the conversation is. So it's doing this, and it's doing this, and it's working with this printer over here, that kind of thing, and then that just, we populate that on the dashboard. So it's not real time, it's near real time.
Was it able to track infusion pumps?
Yes. Well, you can pull up the location history of the infusion pump.
Okay, so to answer your question, so we're currently working on some integrations with some RTLS companies, but the way that we actually can identify geographically where a device is today is through, so we can see it, if it's a wireless device, we can see where it's connecting to your access points, okay? Within the hospital, they're going to know what an AP is. There's probably a couple of rooms somewhere, working around and up here. It's basically taking a wireless device and providing, its connectivity within each hospital room. From a connected device, we do it through integrations with your switches, like a Cisco ICE or Force Scout, Aruba ClearPath, stuff like that. Okay.
If device is shut down, it doesn't have the battery, then how you can press that?
Say that one more time.
If the device doesn't have the battery, then how you can press that?
It doesn't
Are
have
you
the
talking on the RTLS side?
Yeah.
Yeah, so we're not RTLS. And so we're not as precise as RTLS, but you also don't have the battery issue. And so the question was on RTLS. The big issue with RTLS is batteries die. And
So we don't. So we wouldn't recommend that you rip and replace. We're not another solution for your RTLS program, right? What we're finding is we can show you within an access point. Basically, it's going to be on the 4th floor, room 128, within about 20 feet. Okay, and so what we're finding from really not just a security perspective, even a clinical perspective, that that's enough. Okay, now we're not in the market to go rip and replace RTLS systems. We're actually beginning to integrate with RTLS, but we can show you within like about a 20-foot radius where specific devices. Okay.
the way to think about our platform is it's what I call, we integrate with anyone, anytime, anywhere. We'll send our smart guys over, talk to your smart guys. We've got this data set that can make your tools better. And what we're turning into is this collaboration machine and a single pane of glass where right now there's some of this information's over here, some is over here, some is over here. We're trying to get it all aggregated so that, whether you're clinical engineering, ITIS, or even leadership or supply chain, you have one place to go to get the information you're looking for.
So when you think about like just the logos that are up here, I'm sure so many organizations. Again, from a clinical side, most folks are looking at their CMS platform to understand the inventory, where it all begins. So we integrate into all of these platforms. So what I mean by that, we'll actually correlate. So let's say we come in and plug our platform in, which all we do is just plug in through span ports or through network tabs like Gigamon, whatever. And we can pre-configure our 1U device remotely, send it, plug it in. We call it the latte PLD. It's 15 minutes to get lattes, right? By the way, it's all passive and we don't store any PHI data. So when you think about that, we then correlate, let's say, give us 7 to 10 days of what I call turn the lights on. Again, really understand what it is that you're dealing with. We correlate it then with your CMS or CMBD inventory, okay, to see what you guys have. We usually find about a 30% delta. And then we actively feed that in real time directly into these platforms.
And the way we do that is because we speak the languages, we get down to serial numbers. And now we can match the CMMS serial number, the serial number. That's why most of our competitors fail at this, because they don't get to that level of detail of what the device is.
So these aren't our competitors. These are our partners. Our competitors being the Zingbox, the Armis, some of the NAC players think they can identify connected medical devices, but they run at about 30% of what we see. I think, John, just to be clear, these organizations aren't failing at the identification because they're not tasked with that. Where we enrich these investments that you guys have been making is that they actually have real time, that 30% delta is gone. We provide analytics that you can then put a strategy.
And now instead of the manual inventory, you have on all your connected devices, you have real time. That's a massive step up in value of the CMMS.
So let's start talking about what happens, once you guys buy in and you're drinking my Kool-Aid around the inventory, right? There's like, we get a lot of wows, like, wow, that's amazing, but now what? So kind of start talking about what does this mean to the business? How am I going to make money, save money, or mitigate my risk, right? So kind of where this whole conversation's been going. So it's really demand-driven reallocation, utilization. So you can see here, we consistently track what the devices will be needed. We do this by saying, okay, you have 2,000 infusion pumps. 700 of them we have not seen on your network in a month, okay? Okay, well, that's really interesting, Tyson. So where the hell are my 700 infusion pumps? Well, I bet you 300 are stashed in like closets or in the ceiling somewhere where the nurses put them, right? So when they come in, okay? The other 300 might not have touched your network or the next 200 may not touch your network for six months. So are they retired? Are they out for maintenance? And then the other 300, Mr. Customer or Mr. Prospect is those 300 only are being used 20 to 25% of the time. Okay? Okay, well, Tyson, I just have a request from my CFO to go procure 300 new infusion pumps. How much are infusion pumps? $5 grand, something like that. $3 grand, $5 grand.
$3,600. Yeah.
So it's really demand-driven reallocation. So how am I going to reallocate those 700 devices that my CMF is showing, but I have no idea where they are? Okay, and more importantly, why am I going to go procure 400 more of them?
And the important part about this is this last step. This is about real ROI. This is about cost avoidance. Not every, this is a way to truly, save money as an added bonus on top of all the other goodness that people get out of our platform.
So again, by leveraging that data, first I would say of those 700, what devices am I missing or have we not seen on the network and where are they? Okay, and so we can start saying, okay, so pump number 1301, we actually see it in a closet on campus number 11, floor number 4, and room number 301. Okay. The increased utilization. So let's just touching on that, but we're able to provide up to 42% more efficiency with your current environment of fleet devices, just based by being more efficient with regards to where they're being used. This doesn't just apply to like an infusion pump, but let's think about an MRI machine. And there's an awesome use case that's spun out of Trinity where because of how granular our metrics are, we can actually tell if a MRI machine is providing pictures of someone's elbow, and then the next patient comes in and that person's brain is being looked at. We can provide metrics around how long it takes that operator to actually get that MRI machine ready to go from an elbow to someone that's getting some brain scans done. Okay, and what type of efficiency or how long that's taking an HDO to get that machine ready to go. How many of those images are actually being captured by the EMR? And what does that look like if I have 10 or 12 MRI machines? If I could set up everybody that's getting their elbows or their leg or whatever imaged that entire day versus the brain versus the abdomen, what does that look like from a utilization perspective? No wows yet?
So that actually saved them buying another MRI machine just by changing their scheduling too. Leg, back, neck, and saving all that recalibration time and that slippage that happens in between.
So, with I don't love the name of the slide and your benchmarks, but really it gives you the ability to compare how many devices are deployed per bed, how can you be more efficient, how can you achieve more optimal performance based on each one of those devices. So device maintenance and optimization. So we're agnostic from a manufacturer perspective. We've put a lot of time and money. We're just from a company perspective, we're just a few days away from announcing, or a few weeks away from announcing our growth round of funding. And generally happens in startups. Our trajectory is they go and just pour a bunch of money into global sales and marketing, and they go try to get acquired. We're jumping pretty much, which makes my job more difficult because I'm the one who has to answer to what I call the ivory tower, the investors, right? Around numbers each year, but we're dumping so much of this money into CDE, what we're talking about today, to try to continue to expand the offering. And one of the areas we're investing very, very heavily is trying to integrate with some of the manufacturers. If you think about this, the manufacturers, they look at us as friendly in some areas and not so friendly in some areas. I mean, when you think about this, we're basically saying, look, this operating system is either there's a risk there or it's outdated or whatever. And if we were able to provide much more real-time data to you folks, pushing the manufacturers publicly, they would be forced to release updates to actually fix these OSs versus saying, you know what, that's out of date for 10 years, now you guys need to go procure a new device, right? We are getting there. We're working very closely with Siemens, GE, and Philips as of today, and we think there'll be some really interesting announcements moving forward into 2022, which will deliver a lot more alternative maintenance schedules. Now, we already can deliver some value here, and really it's around a costly and time. We know the problem is costly and time consuming for a device that has only been used scans of the year, based on our utilization, visibility, etc. We're able to provide some value and some ROI around how often that device needs to be updated, maintained, and out for maintenance right now. We also find, just from more of a visibility perspective, it wouldn't be surprised, because what you guys do all day. It was very eye-opening to me that HDOs didn't even understand what devices were set up for maintenance. Okay, and 200 of these devices went in for maintenance or whatever the number is. 8 weeks ago, where are these devices? Why are they not back, making us money? Where's the utilization of these? Why have we not seen these things in use? So this is around low impact of preventative maintenance. And so, when it is time to do some preventative maintenance, finding the device quickly. This goes back to visibility and utilization. I'd love to use the infusion pump example here, just because there's so many infusion pumps in the clinical setting.
And they're the bane of.
Yeah, additionally knowing the operating schedule. So when you kind of think about the utilization and the operational efficiencies, what devices am I going to take out? What devices am I going to remove from billing each month or each week or each day? If I have those 700 devices that I have somewhere in the network, somewhere in the environment, but they're not being used, why am I taking 200 of them down? They're actually billing right now for maintenance. Okay. It's okay. It's just trying to catch up. It's a little bit behind, I think. So it's still, it's going to start here. Maybe I have fat fingers, which
No, I don't think so.
wouldn't be the first time I've been accused of that.
Are you on this one? Let's see.
Does this make sense, guys? Interesting? Any questions? You can just throw them out there.
Are you guys able to track like CTs, size counts for diagnostics?
I don't know the answer to that. I can find an answer. Get with me after and I'll get you guys the answer. Sometimes I like to think I'm dangerous technically, but that's just what I am. Dangerous. Thank you. Okay, so infection control. So again, when you think about whether it's a cyber infection or if it needs to be cleaned or maintained, understanding the location or the utilization allows these devices to be addressed more safely and more efficiently. Vulnerability reporting. So we're a cybersecurity company, but again, very focused on the clinical side of these days. So not only do we track vulnerabilities, we report on them, we provide location of the devices that might be communicating to your EMR and with PHI data that's unencrypted. Maybe there's an infusion pump or an MRI machine or a whatever the device is that's communicating to North Korea or Russia. But we'll then integrate on all this reporting based on your customizations into whatever reporting platform that you're using, whether it's ServiceNow, and ultimately help define best practices based on your specific environment, taking into consideration that generally the biomed or clinical engineering teams are very siloed, and so are the IT teams, and so are the information security teams. But then what? Like, what's the workflow when I see that one of my infusion pumps is connecting to China and is communicating with PHI data that's up here? Okay, what does that mean? And how do I get rid of this? You know, what are the steps to go get rid of this? And we integrate with SIPs. So whether you guys are using, you know, an internal remediation team to do tier 1, tier 2 investigation, or whatever it is, we can actually provide recommendations and real-time reporting based on your environment.
And what that's doing is it's automating that process that right now a lot of people are going, I don't know.
And so let's think about this. Let's say that for some reason you guys hear that there's a set of devices that are communicating that you know, or there's a hack, right? Or something's going on. So what happens? You're probably called security and say, what's going on here? And they're like, cool, great, where's the device? I don't know. So, and I don't know, it's different for each environment and each enterprise as to what that sort of workflow process looks like. Depends on, you know, the ticketing platform you're using. Depends what type of NAC you're using. Depends on if you're doing remediation internally or not. But I think you can probably see when we talk about utilization or operational efficiency, how quickly we can cut that down for all just one data class. And we can actually enforce clinical policy through a NAC to preemptively protect and automate segmentation. So here are, you know, so I'm a finance guy, like I've been in cybersecurity for 12 or 13 years now. And it's funny because ROI in my world is really insurance policy, right? Because how do you actually have a hard dollar cost in cybersecurity when, okay, cool. So if I get hacked, maybe I don't care about those devices. B, I'll just let my security team deal with this. This is from a lens through biomedical or clinical engineering. You know, I'm not so concerned with that. And even if, you know, and I have no idea how long it's going to take me to remediate something. I.e. remediate being, how do I understand what the threat is, or the anomaly is, what device, what, where, who, how, when, and why the device is communicating, yada, 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 and then how do I get rid of it? So that's really, you know, which is extremely important if you ask me.
But it's a cost center. Security and cybersecurity is a cost center.
Yes.
It's a money goes out.
Yes, it's an insurance policy, right?
This piece changes this
Correct.
to the other side of making money or saving money. And no longer a cost center.
Yeah, exactly. And thank you, John. And so when you think about providing a very hard dollar ROI to your CFO, what if you could go to your CFO who had just issued that PO or that the approval to go purchase 300 or 400 infusion pumps? What if you go to that CFO and say, look, we have 700 infusion pumps that we own. They're not being utilized, or 300 of those 700. I didn't know. We didn't know where they were. Now we know where they are. 300 of them are only being utilized 20% of the time. How about if I could, Mr. CFO, what if I was able to show you that we don't need those 300 or 400 infusion pumps? We already have 700 of them, And let me show you why we don't need to go cut this check with Phillips. Okay, and that's really, really hard dollar ROI if you ask me. Some of the other OPEX and cost and CAPEX savings, obviously on the maintenance side, see through like elimination of outdated manual routines, full deal invisibility, incident response, which we talked about, trying to understand, what exactly is happening, where is this device, what's it communicating to, and what is the risk. The asset utilization, how am I going to take this data and allow me to save money because I can be more efficient with utilizing my devices properly. And 4, which is really, it's my favorite use case, is actually going to a CFO and saying, look, I know your security team really likes my platform. I know they say, wow, that's some awesome data. But let me show you your data, Mr. CFO, that your clinical engineering team just gave me, and I could save you $3 million today. And he says, well, what do you mean? Well, you have this $1.2 million purchase order ready to go out for Philips infusion pumps. Here are all these infusion pumps. And I can tell you right now that 9 out of 10 times, once we get to that level, there is no more POV. It's, we're throwing. We can show and we can show you guys and make you guys superheroes in front of your CFOs by providing a very simple financial savings assessment. And again, it's not that I think that cybersecurity ROIs are smoke and mirrors. I think it's a necessary evil. To Jonathan's point, it's a cost center. You're buying cybersecurity software as a policy. There is no insurance policy if we can provide 300 or 400 infusion pumps when you guys need a couple hundred and there's a purchase order sitting there to go out the door. Sure why it's doing that. It's okay.
Are we going to show real money there? Any questions? What do I hit to get it back up?
Sorry, I don't know why it keeps fast forwarding through there.
Sorry.
And we only have 2 slides left.
Okay.
I think it's step 1. What's back?
So that's fine. Right there's fine.
Done.
So look, here's kind of what I'm talking about. So, an example of like an ROI. We're happy to show you guys what the calculator looks like, but 700K in device replacement versus cancel.
And this happened when we plugged in a POV.
Yeah.
Okay, they had $700,000 PO all written out for a bunch of infusion pumps, and the HTM leader was like, I know we bought these last year. I know we bought them. And when we plugged in, they showed up, and we're in POV. We don't even have a contract with these people. Saved $700,000. And then as we started to work with them,
That's actually a different HTO. So there's a different use case, but yeah. So this is actually our first one of our first customers in Australia, and they just signed a contract a couple months ago. They were also in POV. The reason why they did a deal is it wasn't so much around their fleet devices, but they had a capital expenditure order to go out and buy a new C-arm because of our utilization. They literally did not buy the C-arm, and that is referenceable as well. Another customer, which by the way, these were all referenceable. Just wasn't going to put them up here in front of our competition. They're here today. We also have a business use case from an HDO here in America. It's actually a top 10 around the $3 million in savings they see just from their fleet device improved utilization metrics. Keep in mind, we've been providing some of this utilization metrics for the last 4 years as we've been really growing what we call this module. We just released the CDE module less than a month ago. These are 3 use cases we've already seen, so people are willing to speak about them. So hence why we call it clinical device efficiency. I think that's it.